All right, we're going to talk about labor. Okay, so chapter 29, development. Okay, we've talked about pretty much how we have the fertilization and then the development of that fertilized oocyte, now an ovum, once it unites with the sperm, and how it develops into a blastocyst, and then into a zygote, and then into an embryo, and then into our fetus, okay? And then eventually at birth, we got a baby, okay? So I want to talk about labor, also known as parturition. Where are we? All right. So what is labor? All right. Labor is literally the physical expulsion of the fetus. Basically, it's the physical expulsion of the contents of the uterus, and that includes, all right, the fetus and the placenta. Okay. All right. Typically, a full pregnancy carries up to 38 weeks, okay, for what we consider to be full term. Okay, sometimes it can go as long as 40 weeks, all right? So this process of labor, all right, involves contractions of the muscles, namely, all right, the myometrium of the uterus, all right? But we have to discuss that there's true labor and then there's false labor. So not all uterine contractions will lead to true labor. And you probably heard the term the Braxton Hicks contractions, in which that is considered to be false labor, and that can start as early as the second trimester, all right? But usually the Braxton Hicks don't increase in frequency and intensity. Plus, if you cause certain movements there, you can sometimes arrest or stop the Braxton Hicks. We'll talk about that in a second here. All right. But what we're going to see, all right, when we're talking about labor is, again, when we're dealing with the endocrine function here, we're going to see increased levels of estrogen. All right. And so the nice thing about the increased levels of estrogen is that it's going to increase the sensitivity of the myometrium to oxytocin. And oxytocin is that hormone that's produced in the hypothalamus, stored in the posterior pituitary, and secreted by the posterior pituitary, all right, to create, all right, uterine contractions. Okay? So estrogen will help, all right, the myometrium become more sensitive, all right, to oxytocin. So the oxytocin receptors there, all right, when it's being produced into systemic blood flow, all right, it will allow for a much more effective binding of the oxytocin so we can get those contractions, all right, ready and prepare the uterus for the ejection, the physical ejection of the fetus there, okay? So in the beginning, all right, when we talk about the contractions, they're going to start out relatively mild, all right, and somewhat infrequent. Okay, there's not going to be, you know, like one every minutes or one every 2 minutes. Okay, it could be one every 10 minutes or even longer than that. All right. So we'll see some of these contractions from time to time. All right, starting in the second trimester. Okay, but as I've told you before, as we get further along in the pregnancy, our estrogen and progesterone levels will start to increase. All right, and so as we get that increased levels of estrogen, we are starting to build up those receptors for oxytocin, all right, in the uterus to prepare for, all right, labor and delivery. All right. So what is premature labor? Well, it's exactly what it says. All right. It is going, when we come to full term, that's about 38 weeks. So prior to 38 weeks, we refer to it as premature labor. Now, obviously, it's like, and I hate to compare a developing fetus to brownies or a cake, but it's just like anything. When you put something in the oven, if you take it out before it's done cooking, all right, you're not going to have a complete finished product. Same thing, all right, with the fetus. All right, a lot of times there's a reason why, all right, full-term pregnancy is 38 weeks. One is to make sure that the fetus is able to survive on its own outside of the womb, all right? But two, we have to develop, all right, so these organs here, all right, to sustain vital functions of life. Okay, so premature labor, and again, depending on when that occurs, if the actual birth of the fetus happens, all right, we have to take into consideration what's going on with all of the body's organ systems. The lungs especially, okay? The lungs are very, very delicate, and especially when we get to that point where if it's prior to, and I want to say it's 24 to 26 weeks, if a baby is born before 24 to 26 weeks, it is a very concerning thing in regards to the lungs, because the lungs have not yet produced that surfactant. And that surfactant is produced by those pneumocytes in the alveoli. Surfactant helps to keep your lungs inflated. If you're not producing surfactant, all right, then it will decrease the surface area of the alveoli, and you won't be able to maintain normal function of breathing. So if a baby is born premature, okay, a lot of the times they'll put them on a respirator or in an incubator, but they'll try giving the baby steroids, because believe it or not, steroids to these young children can actually cause the pneumocytes to produce surfactant. All right, so the more premature our fetus, all right, the higher the risk for morbidity and mortality, okay, which is bad things and death. All right, talking about the Braxton Hicks here, all right, we're going to see, all right, some of the characteristics for Braxton Hicks are irregular space, they don't come in at regular intervals, all right, and they don't come very frequently. All right, important that they also do not increase in intensity like true labor does. All right, Braxton Hicks do not. All right, so you encourage the patient to start to move around a little bit. Does that relieve any of the complaints? If it does, most likely it's Braxton Hicks. If not, then it's still potentially, it could be the onset of labor. All right, but the big thing is we do not see any changes to the cervix. All right, during the birthing process, the cervix is going to thin out. All right, it will no longer have that big thick donut there. All right, it will start to thin out, and the actual cervical canal will start to enlarge. All right, we call that effacement. Okay, so when we talk about labor, there's 3 stages to labor. All right, so let's talk about what is going to happen here. Now that we get to true labor, all right, this is actually, we're getting ready, it's game time. It's time for baby to be born. All right, so now we're going to see exactly what is going to take place, all right, to help with this process here, okay? So first of all, true labor involves obviously uterine contractions that are going to increase in frequency and increase in intensity, and we're also going to see some changes in the cervix. We're going to see, all right, like I said, that thinning of the cervix, and we're going to actually see that the cervix, the cervical canal, open and become larger and larger, okay? So what we'll see as true labor sets in, we're going to see in the endocrine system-wise, mom's hypothalamus is going to be producing oxytocin. All right, don't forget, oxytocin plays a role in milk ejection, but it's not time for that yet, all right, because the baby hasn't been born. So oxytocin is going to play a role in uterine contractions. Well, guess what? Mom's not the only one that makes oxytocin. The baby does too. So now you have 2 sources for oxytocin production. Okay, that's great, because what we're going to see is that oxytocin then is going to, we're going to have more than enough that is going to stimulate the myometrium to begin its contractions. While that's occurring, all right, we're also going to see the placenta, all right, it's going to secrete prostaglandins. Those are our locally acting hormones, all right? So in addition, we'll see more uterine contraction, but now we're going to see, all right, the cervix start to soften up, it's going to thin out, and it's going to start to dilate. So that opening will, in the cervical canal will start to grow bigger here, okay? So the combination of both mom's oxytocin and baby's oxytocin is going to help to initiate our true labor, okay? We're going to get this vessel, this body, mom, ready, all right, for the birthing process here, okay? So a couple things to look for when we're talking about true labor, all right? We're going to see an increase in frequency of contractions, increase in intensity, all right, as labor progresses. All right, a lot of patients will complain of pain in the low back and upper portions of the abdomen here, but a lot of low back pain will be involved here, all right? And even though the patient's moving around trying to find that comfortable position, all right, normally we don't see any relief to any of those pain symptoms with position changes, okay? All right, so remember way back in chapter 1 when we were talking about homeostasis? And part of homeostasis, yes, it involves the receptor, the control center, or the effector, right? But we talked about two mechanisms that help promote, all right, and maintain homeostasis. We learned about negative feedback mechanisms and positive feedback mechanisms, all right? Most of the feedback mechanisms are negative feedback mechanisms, all right? If your body gets too hot, your body starts to cool it down, okay? So the response to whatever the stimulus is usually in the opposite direction, where we're dealing with negative feedback mechanisms. Now we're going to talk about positive feedback mechanisms. And positive feedback mechanisms, all right, are going to help to sustain, all right, whatever the stimulus is for a desired outcome or a specific outcome, okay? So when we talk about the positive feedback mechanism of labor, all right, there's going to be a couple things that are going to help with that. One is, where's the baby's head? Baby's head's on the cervix. So the physical presence of that baby's head pressing on the cervix, all right, is going to continue contraction production in the uterus there, okay? So as the baby's head is pressing on the cervix, that's going to cause a response from the uterus to contract more. What's that going to do? That's going to further push the baby's head against the cervix. As that is happening, the cervix now will start to stretch and thin out, all right, and it'll dilate. So the cervical canal opening, the internal os, external os are going to widen and become more dilated and larger. So as that's going on, the hypothalamus, all right, in both baby and in mommy, are going to be secreting more oxytocin, which is going to now increase, all right, the uterine contractions. And while that's going on, we can't forget about our local organ, the placenta. It's going to secrete its prostaglandins. And those prostaglandins are going to further promote uterine contractions, all right? And there are certain prostaglandins, all right, that will cause softening of the cervix. There's actually a drug, all right, normally the popular drug for inducement of child labor is Pitocin. All right, everybody likes the Pitocin because it helps. Well, they don't like it, all right, because it can cause pretty forceful contractions. But there was a drug that they used with my wife. It's called Cervidil, and basically they administer that directly to the cervix, and it causes the cervix again to soften and start to dilate. And basically, Cervidil is prostaglandins. All right, just sounds cool. All right, so as you know, with true labor, all right, in the beginning, those contractions will start off, all right, relatively weak, all right, and infrequent. And then as this positive feedback mechanism continues on, now we'll start to see an increase in frequency of contractions, all right, and an increase in the intensity of the contractions, until finally, once the fetus has left, all right, has been expelled from the uterus, all right, now we've taken away our stimulus. There's no more baby's head pushing on the cervix. All right, baby's no longer inside mom, so it's not giving its oxytocin over to mom's bloodstream. All right, so we're going to see a significant decrease in oxytocin, all right? But big thing is, after the fetus is expelled, what comes after the fetus? The placenta, all right? And once the placenta is no longer inside, all right, in the uterus, all right, now we've just took away a large source of prostaglandins here, okay? So once all these things start to decrease, then we'll start to see a decrease, all right, in contractions and a decrease there, all right, and the force of contractions and the frequency until eventually they're done, okay? All right, this diagram here shows us our positive feedback mechanism here. It's a lot to take in. It's a big, big cycle here. But basically, I'm going to start over here on this side. Here you can see both control centers for mommy and for baby, all right, both of their hypothalami are producing oxytocin, okay? And so that oxytocin, all right, is now going to stimulate the placenta to make prostaglandins. Those prostaglandins, all right, again, will help with more uterine contractions, as will the oxytocin, but they'll also help to soften and dilate the cervix. All right, so the oxytocin now is causing contraction of the uterus. All right, prostaglandins that are being produced by the placenta are also going to contribute to uterine contractions and also softening and dilation of the cervix there. All right, and then both of those will push the baby's head against the cervix. All right, which will then cause more forceful contractions, all right, and dilation of the cervix, all right. So we see that the presence of the baby is going to be increasing, all right, the stimulus here, and over time, eventually, when the cervix is dilated enough, up to 10 centimeters, all right, and the contractions, along with mom helping out by doing her breathing and pushing to help expel the fetus, eventually we're going to expel the fetus. And that is then going to cause, you know, a big, huge drop in oxytocin levels, a big, huge drop in prostaglandin levels, which will eventually cause a drop in uterine contractions and eventually a halt to labor. I can't talk. All right. So the first stage of labor. Okay, so there was 3, is the dilation stage. Okay, so baby's sitting up in mom's uterus, all nice and cozy. All right, the passageway is nice and tight. There's no getting out. All right, so now what we're going to see during this phase here, all right, we're going to see changes in the cervix. Okay, so the cervix, all right, as it goes through the dilation stage, is going to continue to thin, all right? And as it's thinning, it's going to dilate. And eventually, once we get up to 10 centimeters of dilation, all right, is ample size for at least a normal-sized child, all right, for childbirth, for the passage of the baby, okay? So the dilation stage is the longest, and it varies, all right, from woman to woman. All right, but normally and usually the trend is, if you've never had a baby before, all right, we refer to them, to those ladies as nulliparous, all right, it will take, this stage will usually take a little bit longer, anywhere between 8 to 24 hours. I've seen with some patients where it's been up to 36, 40 minutes, yeah, yeah. Again, it can be long, all right. Then in women that have given birth, all right, parous women, all right, the stages can be significantly shorter, anywhere from 4 to 12 hours. All right. When my wife was pregnant, our son was 10 days late, so she had to get induced. And so, yeah, you were 10 days late? Yeah. He didn't want to leave, apparently. So I don't blame him, because it was one of the hottest weekends in New York at the time. I think it was 98 degrees in September on a weekend. It was hot, hot. So anyway, and I lived in an apartment. We lived in an apartment in which we didn't have air conditioning. So, oh yeah, yeah, oh yeah. So, anyways, when they gave her the Cervidil, it took, I want to say, we were there in the afternoon. I don't think she didn't deliver until around midnight. So it was close. It was right in this window here, the 4 to 12 hours. She was her dilation stage was relatively short. But again, it's because she was being induced. All right, and then I think she dilated to 6 to 8 centimeters, and they offered her an epidural. She took it, and it's a good thing she took it when she did, because after they were done with the procedure, she was 8 centimeters dilated. And at least in the hospital that we were at, you can't give an epidural if they're past 8 centimeters. I know it varies from hospital to hospital. But anyways, so that's the first stage, all right, dilation. We've got to get the cervix thinned out so it's no longer thick, so it's no longer this big thick donut. All right, we want it to be a thin donut, okay? All right, and then dilated. We can't have it being, you know, this small. We need it to be, we need that opening, that cervical canal to be huge. Nice big opening now. All right, so that's the first stage there, okay? So again, during this time, we'll start to see some uterine contractions occurring. Again, nice and slow, easy does it, wins the race. All right, nice steady intensity and frequency. All right, and during this time now, we're seeing baby's head. All right, in a normal, well, in an ideal pregnancy, I should say. I shouldn't say a normal pregnancy, but an ideal pregnancy, baby should be head down. Okay, we certainly don't want to breach. Okay, but head down baby is preferred, and so the baby's head will be pressing against the cervix, which will help with effacement and dilation. All right, it's during this stage where you've heard the famous term, my water broke. Okay, and this is where we see the rupturing of the amniotic sac there, amniotic fluid leaving, all right, through the birth canal. All right, and in some situations, this happened with my daughter. My wife's water did not break, so they actually had to go in there and manually rupture the amniotic sac there. And it was amazing. The tool that they used, it literally looked like a knitting needle. All right, the one end of it had like this hook on it, looked like that. And so what they would do is just kind of scrape this hook back and forth, and apparently they were scraping that hook across my daughter's forehead because she had all these scratches on her forehead, and they used this hook to kind of tear the placenta, the amniotic sac there, to break the water. Oh, trust me. I was actually fortunate enough to, well, I was in the room for both of them, but the doctor actually let me deliver my son. It was cool. I'll tell you a story here in a second. Yeah, it was pretty freaking amazing. Anyways, so when we're looking here at the pictures here for our true labor, all right, you can see, oh, there it is. All right, so you can see here's head down, all right, and the baby's head is pressing up against the cervix here, which will cause, all right, that effacement and that dilation opening up here, all right, that cervical canal. All right, and as that the baby continues to press its head against that, all right, we'll get uterine contractions here that are going to keep pushing baby's head, like bouncing the baby's head against that cervix until we get to that 10 centimeters dilated here. All right, once we get there, then now it's time. Now the real work begins. Okay, this is where a lot happens here. So, of course, that's the second stage, the expulsion stage. All right, this is when we got to get rid of the baby. Okay, baby's got to go. All right, so this is where we're going to see complete dilation. All right, so we're at 10 centimeters. All right, cervix is completely effaced. It's thinned as far as it'll thin. All right, dilated at 10 centimeters. Now it's time to move the baby out. So again, this stage can go from a minimum of about 30 minutes, and in some cases less, to several hours. And I was very fortunate. My wife was very fortunate that she was, I think, for our first delivery, she was over 30 minutes. For some reason, 38 sticks in my head. All right. She actually was in active pushing for 9 minutes, which was really, really good. All right. So this is where you hear, you know, the doctors or whoever's in the room, midwife, whoever, all right, telling mom to bear down. All right. Just start pushing, start breathing. All right, and so as we're doing this, the uterine contractions, in addition to mom bearing down, that helps to increase that intra-abdominal pressure, like the Valsalva maneuver, which will help to push the fetus through the vagina. Now this term here, crowning, I'm going to show you a picture, all right? So this is what we're looking here as crowning, where the head, all right, literally starts, all right, to emerge from the vaginal opening here. I'm going to tell you something, all right? This is a very, very nice picture because when my son was being born and I was down there looking at that, you got to understand that you're squeezing a head the size of a softball or baseball through a small opening. So and as we all know from our anatomy with the skull, right? Baby's skull, the suture joints aren't suture joints yet, right? The bones can overlap each other. And so when my son was being born, he was doing everything right apparently, but his bones, his skin was all wrinkly and it looked like gyri from the brain. So I started freaking out internally. Thank God I didn't make a. I'm like, oh my God, I can see my son's brain. But I wasn't. There was a lot going on in the room. All right, a lot was happening. But basically, it was just the folds of the skin pouring over. But that's what we're seeing here. All right, with the crowning, the tip of the baby's head starts to emerge through the vaginal opening here. Okay. All right. So in some situations, all right, the healthcare team that is going to be present in the birthing process might have to administer what we call an episiotomy. An episiotomy is when they have to sometimes snip the more posterior portion of the vagina. Like if here's the vaginal orifice here, all right, and the anus is down here, all right, they have to snip this area here. I say snip, usually use a scalpel and kind of give small incisions, because if the opening isn't big enough or if the baby's head is too big, all right, or there's not enough stretching going on, we don't want to tear the skin there. That's a bad, bad thing that can happen, all right? Just talk to anybody that's ever had something like that happen. So what they'll do is they'll give a small incision right down here at the bottom of the vaginal opening here, all right, to actually make that opening a little bit bigger to accommodate the baby, okay? And so sometimes what they'll have to do is hard nose. Everybody, my cousin said that, and she still had a kid. But I know, it doesn't sound, trust me, this is not all, it does. It does. It does. It blows my mind how any woman, you know, especially after having the first child, I'm like, well, how?
It's easier the second time. Everything's all stretched out.
I've got a family of patients of mine. She's got 12 kids.
What?
Yes, 12 kids. And I'm thinking to myself, it's amazing to me that, I mean, I could say, all right, maybe 3, 4. I'm Irish, so, you know, we like to have big families. But, I mean, 8, 9, 10, 11, 12?
It's making me nauseous thinking about one.
Trust me, I know, I'm sure everybody says that, but I couldn't tell you because I've never had a child. So, but I can only imagine that thought process. All right. So after the baby has been expelled, all right, remember the placenta is still in the uterus, but the baby is still attached to the placenta via the umbilical cord. So this is where they'll clamp off the cord, all right, tie it off, and then actually cut it, okay? So you can see here now as the baby's head is, once the head is out, the rest, and I'm not like I'm a professional here, I've only delivered one child, all right? But once the head is out, everything else usually comes out much easier. Once you move the shoulders out and everything, it just, you'll be amazed. One push and the rest of the baby comes out. Yeah, as long as there's no complications. It's easy for me to say that as long as there's no complications. All right, the last stage is the placental stage, okay? Like I said, after the baby leaves, there's only one thing left inside the uterus, and that's the placenta, all right? Often known as the afterbirth here, all right? But after the child is left, the uterus is going to still contract. And the reason why is because it needs to kind of shake loose the placenta from the uterine wall. It's not always that easy to do because we don't want to cause any tearing, all right? That could be very, very dangerous, all right? We certainly don't want it, because think about it. Right now, the internal lining of that uterus is highly engorged with blood vessels, all right? So we want to make sure that we don't cause any unnecessary bleeding, all right, because you don't want to have mom, after going through that ordeal of the actual childbirth, to have to experience blood loss too, all right, and to excessive degrees, depending if there's any tearing of the blood vessels. So this is where you have to be careful. But with the placental stage here, all right, the uterus will continue to contract, which is nice because it compresses uterine blood vessels, and when we compress those blood vessels, all right, then we can shunt some of the blood away from that organ, from the uterus, all right, so then we can displace the rest of the placenta, all right, from the internal lining of the uterus here, all right. So usually, again, not too much attention, for me at least, on my kids when they were born. Was placed on waiting around for the afterbirth. I was over there trying to take care of the kids. Make it sound that easy, but it's not that easy. All right, but that could take up to 30 minutes. All right, but the big thing is we have to make sure, all right, when we're dealing with the afterbirth, to make sure you get all of that tissue and that you don't tear any of the tissues inside. All right, especially that uterine lining there. Okay. All right, so here, after the expulsion phase, we have, all right, the placenta still inside with the attached umbilical cord here. So they'll clamp that off, then cut it, and then as the uterus continues to contract, all right, trying to shake the placenta loose from the uteral wall lining, then they'll ease out the remaining portion of the placenta, all right, and here you can see, just, again, depending on your thoughts on this, you can see just how much blood can go to that organ. It's incredible. I mean, just from this, and this is after, but during the time when the child is actually inside mom, there's a significant amount of blood flow to that area there.
How big is it?
Uterus? Excuse me, the placenta? I'm trying to think if I can see anything in here. Probably about as big as this bag here. Yeah. Not, you know, small, like a brown paper bag, maybe, like a lunch bag kind of thing. Yeah. All right. So let's move on. Now we're done with birth. Now we got to take care of this thing. All right. We got to feed it somehow. All right. So we're going to feed our child, all right, our baby, all right, with breast milk. Okay. So that process is called lactation. And when we talk about lactation, we're dealing with two things. One, the production of the milk, and then the expulsion or release of the breast milk. All right. As you know, we discussed this before. It involves our mammary glands. Okay. So there's going to be two hormones involved with this. The first one, prolactin. All right. Prolactin is produced in the adenohypophysis, the anterior pituitary. All right. And it makes milk. You need to know that. All right, produce prolactin, all right, produces milk, all right. Now, interesting enough, all right, this is one of the first times that we're going to be discussing dopamine, all right, but what will happen is, all right, normally, all right, when prolactin levels are being produced, or hormones are being produced, all right, we'll see a decrease in dopamine, okay. But in non-pregnant women and in men, all right, because we also can produce prolactin, all right, prolactin secretion is inhibited by dopamine, all right. But in pregnant women, or excuse me, I shouldn't say pregnant women, but women that just had a baby, all right, their dopamine levels will be low because their prolactin levels will be elevated. So therefore, they'll be able to produce milk. Okay. And also, remember what I said, near the end portion of pregnancy, you can see estrogen levels increasing. Okay. So because of these high levels of estrogen, that will also increase prolactin levels. All right. So dopamine decreases prolactin production. Estrogen will increase prolactin production. All right. So the first product that comes out of the breast after the baby is born is colostrum. okay? It's similar to milk, all right? It's a little bit more watery. It has less fat in it, all right? But it is loaded down with some delicious immunoglobulins, IgAs. And this is where, when we talked about immunity, both passive and active immunity, all right, this was an example of passive immunity. Passive immunity is mommy passing her antibodies on to her baby. Okay, they don't last as long, all right, but it's better than nothing, all right? And so this will help with the baby's immune system. In addition, the colostrum will act as a laxative, all right, to help with, all right, the baby's first bowel movement, okay? If anyone's ever seen a baby's first bowel movement, it looks like black tar, like the background to this screen here, all right? They call that meconium. And it's like a black tarry type of product there. And it really looks like tar. All right, so breast milk, okay? Breast milk starts to come in after a few days after pregnancy here. It will have a larger fat content, all right, but also it's loaded with proteins. It's got lactose in it, which is going to be loaded with some carbohydrates, all right, and it's also going to have, all right, more immunoglobulins and our fatty acids. And we love fatty acids, all right, great for energy production, all right, and guess what? Helps us out with digestion because it hooks us up with some enzymes for the chemical digestion of that milk product that the baby's taking in. So all in one serving, they're getting enzymes for digestion, all right, for that chemical digestion. They're getting a laxative to help them pass through, all right, those bowel movements there, and they're getting nutrients, all right. They're going to be getting some carbohydrates. They're going to be getting some proteins, all right. Here are the proteins, those immunoglobulins, and fatty acids, okay. Ideally, most physicians really do push, all right, breast milk over, all right, formula, but there are certain situations in which babies do have to have breast milk substitutes, formula, all right, and obviously you can't let a child starve. Doesn't work like that. All right, so now what we're going to see is the breasts start to produce the milk, okay, but now we have to release the milk, and we refer to that as the milk letdown here. All right, again, we're going to be dealing with another positive feedback mechanism, and we talked about this briefly in chapter 1 when we were learning about the negative and positive feedback mechanisms here, okay? So when we're talking about, all right, milk letdown, it starts off with the child suckling at mom's breast, all right, on the nipple area there, okay? There's mechanoreceptors in and around the nipple and the areolar, all right, which will respond to that stimulus of the baby suckling. And that will stimulate the hypothalamus to release, here it is again, oxytocin. Okay, you just got done releasing a bunch of oxytocin earlier, all right, during labor. Well, guess what? Now we're going to release some more oxytocin because we need to get that milk ejection. We have prolactin, which is present for the milk production, okay, but we need to expel the milk from the breast, all right, to the infant here. So in the breast, we have these myoepithelial cells, MYO. Myo is muscle, so these are a special type of epithelial cells, all right, that have a muscular characteristic to them, and it helps to contract and push on those acini cells in the breast tissue there, all right, to move the breast milk into the lactating ducts and into the lactating sinuses there, okay? And so as long as the baby's there suckling, mom will keep producing milk and she will keep ejecting the milk, all right? You've heard of the saying, you don't use it, you lose it. That's what happens here, all right? When we're talking about lactation and breastfeeding is if the baby is not feeding frequently enough, then mom's production for breast milk decreases, all right? That's how these positive feedback mechanisms work. But if the baby is feeding a lot, all right, and as long as body can handle it, mom will keep producing the milk, all right? So I can only imagine how it is with triplets and twins and all that. That's got to be quite a lot going on. All right. So milk is released as the infant continues to nurse. All right. And because of that, then we'll stimulate further milk production and more milk release. All right. All based on the positive feedback system here, which I'll show you a quick picture here in a second. All right. So here, just to kind of let you see on our little chart here, all right, prolactin levels near the latter portion of the pregnancy start to increase. We're starting to get the breast ready for the production of breast milk here. All right, once birth occurs, all right, boom, all right, those prolactin levels drop down. Okay, but as soon as the baby nurses, you can see a spike. Each of these little spikes is that during that suckling reflex, that prolactin gets released. All right. The prolactin will get released, all right, based on the stimuli of the suckling reflex from the baby there. But once the baby stops, all right, suckling and mom stops nursing, you can see the prolactin levels start to decline until the next feeding, And this will continue, all right, as long as the baby is feeding, okay? But what we'll see, all right, remember what I talked about with dopamine, all right? As prolactin levels are increased, all right, what we'll see is dopamine levels will be decreased, okay? Because the hypothalamus will inhibit dopamine levels. But once, all right, the prolactin levels start to drop off, our dopamine levels will increase, all right? So keep that in mind. They're both antagonistic of one another here. All right. So here you can see our lactation positive feedback mechanism here. All right, the child is suckling with mom here. It causes the mechanoreceptors to send sensory stimulation information up to here to the hypothalamus. The hypothalamus will then release or produce, oxytocin, cause the posterior pituitary to release the oxytocin. The oxytocin will then cause the ejection of the milk from mom's breast, all right, from those acini cells, all right, those glandular cells there, and this will continue to occur, all right, as long as this baby is there, all right. But once, all right, baby stops doing that, because during the suckling reflex, we can see, all right, the hypothalamus is inhibiting the release of dopamine, all right. But once we stop, okay, with the dopamine, then we'll see a decrease in the prolactin there. Questions about that? All right, one last thing, all right, during this whole process too, all right, as long as mom is breastfeeding, and again, I'm making this statement, I am not advocating this for a legitimate form of birth control, all right, but it is harder for mom to become pregnant, all right, because when she is breastfeeding, we are inhibiting the hypothalamus from releasing gonadotropin-releasing hormone. When we inhibit the release of gonadotropin-releasing hormone, we inhibit the release of follicle-stimulating hormone and luteinizing hormone from the anterior pituitary. All right, and without those hormones, we can't have ovulation. Okay, remember, we need those. Follicle-stimulating hormone is going to help with follicular development and maturation. Okay, and we need to have a mature follicle to release our secondary oocyte. All right, so if our follicles aren't developing and maturing, then there's no ovulation. Okay, so again, let me repeat, not a reliable form of birth control. I hear so many people talking about that. You know, I've had patients, moms had breastfeeding and whatnot, and then, of course, my patients tell me things, and some moms have told me, you know, my husband wants to hurry up and have another child, but I'm happy because I'm breastfeeding and I can't get pregnant. I'm like, no, 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 don't think of it like that. All right. So just keep that in mind. All right. So we are going to inhibit ovulation by inhibiting the release of our gonadotropin releasing hormone from our friend, the hypothalamus. All right. That concludes chapter 29. Possibly inhibit. That's a better way to put it. Yeah, sure. You know, there's no absolutes. All right. There's absolutely no absolutes. Notice how it says here, often occurs with regular breastfeeding. All right. Regular breastfeeding is going to be several times a day, every day for a long, when I say a long period of time, months. Okay. Months.
One of my friends, this is a little off topic, but her birth control method was popping pills every single time. She had a baby a week ago.
Oh, really?
Yeah.